Welcome to our presentation on autoimmune hemolytic anemia, a condition where the immune system mistakenly destroys its own red blood cells. In this video, we will guide you through the different types, mechanisms, and diagnostic strategies that every medical laboratory scientist should understand.
To begin with, what exactly is autoimmune hemolytic anemia? So, from its very definition, it is a group of disorder characterized by the immune system mistakenly producing autoantibodies that target and destroy our red blood cells. Now, what exactly is the mechanism of destruction involved? Looking at this flow diagram, shortened red blood cell lifespan occurs when autoantibodies bind to the red blood cell surface antigens and marking them for destruction, either via intravascular hemolysis or extravascular hemolysis. This leads to a trigger compensatory response by the bone marrow, whereby they increase the erythropoiesis process of whereby red blood cells are increased in production, and this is evidenced by the elevated levels of reticulocyte counts in our blood. And lastly, the consequences of this increased rate of destruction of our red blood cells are jaundice, increased risk of gallstone formation, increased risk of kidney damage, and also can lead to hemoglobinuriria. Moving on to the key components involved in this disease. First up are the antibodies IgG and IgM. IgG is involved in warm autoimmune hemolytic anemia, whereas IgM is involved in cold autoimmune hemolytic anemia. The second key point are the complement proteins. This group of proteins enhances the immune responses, which are activated by antibody-bound red blood cells, amplifying this bounded red blood cells destruction. Lastly is the hemolysis. Hemolysis is basically the breakdown of red blood cells, and here it is characterized into two categories: intravascular and extravascular. Intravascular red blood cells are destroyed within the blood vessels, and extravascular red blood cells are phagocytized by macrophages in spleen and liver. Now, moving on, how this immune hemolytic anemia is classified. They are basically classified based on the location of hemolysis, either intravascular or extravascular. They are characterized by the temperature, either they are warm autoimmune hemolytic anemia or cold autoimmune hemolytic anemia, and lastly by the cause. Either they can be drug induced, whereby certain drug induces autoantibodies, for example penicillin, and the second most likely cause is the autoimmune, where it is characterized into two bases. First up is the primary idiopathic, where there is no identifiable cause and the immune system spontaneously produces autoantibodies against our own red blood cells. Lastly is secondary, whereby it is triggered by underlying conditions such as systemic lupus erythematosus or rheumatoid arthritis, which lead to this autoimmune disorder.
Warm autoimmune hemolytic anemia, which is characterized by the production of autoantibodies, primarily IgG, which bind to red blood cells at body temperature, approximately 37 degrees Celsius. These IgG-coated RBCs are then targeted by splenic macrophages, leading to extravascular hemolysis. Some lab findings, so some tests that can be conducted, and the results would be for direct antiglobulin test, typically positive for IgG, and may also show complement component C3. Next we have is peripheral blood smear. This shows spherocytes, which are small dense red blood cells with lost central pallor, indicative of extravascular hemolysis. Next we have is reticulocytosis. This reflects bone marrow response to anemia. Next is the increase of lactate dehydrogenase. This is a marker for cell breakdown. And then finally is for the decrease in hepatoglobulin. This is due to the binding of free hemoglobin released during hemolysis. A clinical insight of a warm autoimmune hemolytic anemia: it should be considered in elderly patients presenting with unexplained anemia and a positive DAT. The diagnosis may also be delayed if hemolysis is mild or insidious.
Cold hemagglutinin disease is a type of autoimmune hemolytic anemia where cold reactive IgM autoantibodies binds to red blood cells at temperatures below 37 degrees. This leads to the complement activation and subsequent extravascular hemolysis, which occurs primarily in the liver. CHD can be primary, which is idiopathic, or secondary due to conditions like infections, autoimmune diseases, or lymphoproliferative disorders. Patients often present with anemia-related symptoms such as fatigue and pallor, acrocyanosis, and characteristic jaundice, which may be due to elevated bilirubin from hemolysis. Some of the diagnostic tests to identify CHD include a CBC, which may be indicative of anemia, elevated reticulocyte count, and positive DAT for complement component C3d, and elevated cold agglutinin titer. Paroxysmal cold hemoglobinuria is a rare autoimmune hemolytic anemia characterized by the presence of donut-Lensteiner antibodies. These biphasic IgG autoantibodies binds to RBCs at cold temperatures and activates complement at body temperature, leading to intravascular hemolysis. It is often caused due to viral infections such as measles, mumps, or Epstein-Barr virus, and historically associated with syphilis. PCH is now more commonly seen in children post-viral illnesses. Some of the clinical features include sudden onset of hemoglobinuria, which is simply dark-colored urine, and back and abdominal pain, fever, and chills following cold exposure. Symptoms result from acute intravascular hemolysis. Some of the tests that are used to identify this PCH include Donat-Lensteiner test, which confirms the presence of DL antibodies. Other laboratory findings include elevated lactate dehydrogenase, decreased haptoglobin, and hemoglobinuria indicate intravascular hemolysis.
Drug-induced hemolytic anemia. So by definition, it occurs when a medication triggers the immune system to mistakenly attack and destroy the body's own red blood cells. This early breakdown of RBCs is called hemolysis. So why does this happen? Some drugs can cause the immune system to misidentify RBCs as foreign. The body's response by producing antibodies. These antibodies bind to the RBCs, causing them to break down too early. So the two mechanisms of hemolysis which I am going to discuss is immune-mediated hemolysis and oxidative stress-induced hemolysis. Immune-mediated hemolysis is the most common mechanism involving immune system activation against RBCs. It occurs through three subtypes: the heptin drug absorption mechanism, immune complex mechanism, and autoimmune induction. So the heptin drug absorption mechanism is where the drug binds tightly to the RBC mechanisms, and the immune system sees the drug RBC complex is foreign. Hence, the antibodies are produced, which leads to extravascular hemolysis. And a drug that causes this is an example of a drug which causes this is penicillin. The other one is immune complex mechanism. This is where the drug forms complexes with antibodies in the bloodstream. These complexes attaches to the RBCs and activate complement, causing intravascular hemolysis. Autoimmune induction. Some drugs stimulate autoantibody production even without binding directly with the RBCs. The immune system attacks RBC's antigen on its own. The next one is oxidative stress-induced hemolysis. Some drugs generate reactive oxygen species that damage RBC membranes, especially in people with G6PD deficiency. Some common drugs which causes hemolytic anemia are cephalosporins, nitrofurantoin, and penicillin derivatives. So physical examination finding may show a large spleen, whereas diagnostic tests which can be done on this to confirm whether a patient has a hemolytic anemia or not is absolute reticulocyte count, direct-indirect Coombs test, indirect bilirubin, RBC, serum heptoglobin, lactate dehydrogenase, and urine hemoglobin.
Autoimmune hemolytic anemia can cause intravascular or extravascular hemolysis depending on the mechanism. Intravascular hemolysis is rapid and severe, with free hemoglobin released directly into the plasma and urine. Extravascular hemolysis is slower and macrophage mediated. Let's look at a quick comparison between the intravascular and extravascular hemolysis. Hemoglobinuria is seen in intravascular hemolysis but not in extravascular. Heptoglobin levels drop significantly in intravascular while they drop mildly in extravascular. The site of destruction is in circulation for intravascular and in the spleen or liver for extravascular. Intravascular hemolysis is commonly seen in paroxysmal cold hemoglobinuria or PCH and ABO reactions, whereas extravascular is mostly associated with warm autoimmune hemolytic anemia and chronic hemolytic disease or CHD. Now moving on to the diagnostic workup summary. To differentiate between types of autoimmune hemolytic anemia, we look at first the DAT or direct antiglobulin test to detect IgG or C3 on red blood cells. We also assess the reticulocyte count, LDH, bilirubin, and heptoglobin levels. Lastly, on the peripheral smear, we look for signs like spirochetes and agglutination that help point us toward the correct diagnosis.